Thanks, Matt. So what I'd like to do over the next while is to just talk about how we develop these skills. What was the basis for the task that you're going to work with after this session, and what is the skill set, how to acquire those skills, and how we measure performance. And I think there are a couple things just in terms of context that are interesting to look at. Although laparoscopic cholecystectomy has really taken over from open cholecystectomy, most other operations have not widely penetrated even things as straightforward as appendectomy, despite the fact that there's good evidence that this is a safe and effective way of doing the operation. And the question is why, and what do we need to do to get that out there? The other interesting thing is if you look at the residents' training experience in the United States from the data provided through the Residency Review Committee, you can see that the volume of cases done in the course of their training is actually nowhere near what most people would assume would be required for people to overcome their learning curve, except perhaps for cholecystectomy. So the question is really why and how we can get people to the point where they're confident and able to do these common procedures. So at the beginning, Lee Swanstrom mentioned that the goal of the FLS program was to recognize that in order to be a competent laparoscopic surgeon, you needed to have a knowledge set and you needed to have a skill set. And although we're teaching these things independently, the nice thing about the course is truly it incorporates both aspects, and anything that's teaching just the knowledge without any skills or just the skills without any knowledge is somewhat incomplete. So the challenge is, this is a video clip, if we can get it to play, of from a Heller myotomy, and the skills that people need are quite fine. That is, how do you teach someone to be able to divide the muscle of the esophageal wall without making a hole in the mucosa? You really have to have exquisite depth perception, and you have to have very good control of your instruments. And that's what we're trying to get people to acquire. The FLS course is not designed to walk out of here and do a laparoscopic Heller myotomy or any particular procedure, but to say, what is the skill set that you need to go from open surgery to laparoscopic surgery, and what's the best way of getting it? So if you think about how we've traditionally learned, we've learned by an apprenticeship model. See one, do one, teach one. But developing proficiency is really a little bit different from that. I think the goal of learning anything, whether it's surgery or whether it's sports, is to first learn properly. It's very hard to break bad habits. So if you're going to learn something, learn it well, and then practice it. And then as you're practicing it, it's always worthwhile to get some sense of how well you're doing. Get some sort of evaluation that provides you feedback, and that feedback is then used to direct further practice, and that further practice you could reevaluate, and you constantly see how you're doing in comparison to how you were doing before and to a specific goal, your peer group. If you're a golfer, you might want a score that you're shooting at. In FLS, we have a score that we're shooting at as well. So that's really the process. And we believe that rather than doing this on a patient, taking it out of the clinical environment into a simulation environment is a really effective way, and it allows you to practice at your pleasure, at a time that's convenient to you, without any risk to anybody, and really see how you're doing. I once had the good fortune of golfing with Gary Player, and he was amazingly good. And I said, how could you do these shots over and over again? And he said, the more I practice, the luckier I get. It's not something that has really permeated the surgeon's mindset. The concept of practice actually gets you to do better, and it does. And we've shown that with laparoscopic skills. It probably applies equally well to anything. There's a lot of data on volume outcomes. So one of the nice things about the FLS skills is it gives you an environment to practice and to really see how good you are and to see that you're getting better. So when we wanted to develop this hands-on part of the FLS program, the first step we had to do is to understand what is the skill set that's different in laparoscopic surgery from open surgery. Identify those skills, then model them in a simulator, and then develop a way of measuring performance or metrics. Once we had that, we wanted to make sure that those metrics were meaningful, so they were reliable and valid. I'll talk about that a little bit. Make sure it was practical to implement, and reproducible, so that not only could we do it at McGill, but it could be done anywhere in the world, to develop a test based on this skill set, and then incorporate it with the cognitive part in an integrated curriculum. So that was the objectives of the program. So how did we develop the tasks that you're going to see? And as Lee said in his first talk, that you'll look at these tasks, you're going to say they're very simplistic. I can't believe that practicing moving pegs around is going to make me a better surgeon. The way we did this is we looked at a series of videotapes with a group of laparoscopic surgeons. We would call this an expert panel. And we asked them to list those skills that they felt were distinct in laparoscopic surgery from open surgery. And then once we had those, we modeled them. We then brought them back to another expert panel to say, are we covering the range of skills that we really need to teach, and are we evaluating them in a way that makes sense to you? And the way we wanted to evaluate them was efficiency and errors. If you look at some of the VR systems that are out there on the market, they'll give you things like path length of your instruments, angled path length. Well, our thought was, to the average surgeon, what does a path length mean to you? How do you improve your path length? But you can understand that you're able to do things with equal precision, more quickly, more efficiently, and that you're able to put your stitches exactly where you want them, and that your knots are square. Those type of things, I think, are the metrics that make sense to surgeons, and that's why we incorporated those into our environment. So what are the skills that were listed by the so-called expert panel? Well, the first was that for most people, you're transitioning from an environment where you're looking with both eyes, and you have binocular vision, which gives you good depth perception, to a monocular or one-eye system where you have a tendency to lose depth perception, and you have to identify different cues to tell you where you are in a 3D world. For many surgeons, it's the first time that they're using magnification. Your instruments, as you know, are going through trocars, which fix the access in the abdominal wall, so it limits the motion of your instrument to a fulcrum type effect, like a lever. So if you think about it, if you want the tip of your instrument to move in one direction, your hand has got to move in the opposite direction. And that's something that is not intuitive for some people, and you have to practice that. And if you remember back to your physics of levers and fulcrums, you also appreciate that depending on how much of your instrument is inside and how much is on the outside, you get some amplification. So in fact, you sometimes magnify the distance that the effector tip of your instrument moves with a smaller movement of your hand. And then because you're using long instruments, you may have tremors, and those tremors are actually going to get exaggerated. And when you see yourself trembling, well, in fact, you tremble even worse. So those things are actually worthwhile to start to practice in an environment such as a simulator. The other thing about long instruments is like eating with chopsticks, because you start to dampen your sense of touch, and your ability to feel things through long instruments is different than with your fingertips. So all of these things are worthwhile learning and practicing in an environment outside the operating room. The other thing is, because our instruments are fixed in the abdominal wall, we are much more dependent on using our non-dominant hand to set up the position of the organs that we're operating on for our dominant hand to work on. So you really need to develop this choreography with your dominant and non-dominant hand, which is essential, particularly as you move on from lap chole to more advanced operations. So the skills to be modeled really consist of a coordinated bimanual manipulations in an environment where we're using a magnified monocular optical environment. That's the essence of the transition from open to laparoscopic surgery. And the exercises to do that will ask us to manipulate instruments, to cut precisely while you're providing traction with your non-dominant hand, to learn to control a tubular structure using an endoloop, which is a device that we don't use in open surgery, and to relearn how to suture both using intracorporeal knot tying techniques or instrument ties, or extracorporeal knot tying techniques where you actually fashion the knot on the outside and you slide it down on the inside. Everyone knows how to tie knots and to suture in the open environment, but one of the most frustrating things going to laparoscopy is that it's much more difficult to do in an environment like this. So we'll give you a chance to practice it. Once we developed these modules, we had to make sure, as I said, that they make sense, that there's face validity. So what we did is we took a group of experts, which was composed of the board of directors of SAGES, and we asked them, how well does the simulation that we're providing here really reflect those skills that we're trying to teach, and are we missing anything that in the content that is really essential to the transition from open to minimally invasive surgery? Remembering that we're concentrating on the fundamental skill set. We're not trying yet to teach an operation. So the other goals that we had is we wanted to make a training system that would be reasonably inexpensive, that would be portable, and that would be flexible for you, so that if you decide that you want to get one of these box trainers, you actually can use that same box trainer to put in other exercises. So even though we don't have a continuous suturing task as part of this training system, you want to then move from a single stitch to a continuous stitch, no problem. You just do a continuous stitch on the Penrose drain, or put in another Penrose drain, or put in a foam stomach and practice sewing that up. If you want to go on to single port type surgery, you could make a single port environment and put in a single port trocar in the same box, and you could practice those things. So it really is a versatile environment where you're not locked into a computer programmer having to practice that. If you want to try different minimally invasive surgical instruments, different suturing devices, or different needle holders, etc., you can try them. You can even compare your score so that you get an objective way of actually evaluating the devices that you're going to be using in the operating room. So it's really nice to be able to use the same instruments as in the real world with the same feel as in the real world, and you don't get that in a VR environment. So ultimately we came up with 5 tasks, and we'll go through those tasks. There's Melina there demonstrating those tasks on the right at a younger age, but still doing them expertly. So the idea is that we're working in a box trainer environment. We have a camera that provides a monocular system image that displays on a monitor. You could use any monitor that you have available to you. The cover of the box is opaque, and so therefore only through the monitor can you see what's going on inside the box, just like the real world environment. Just different versions of the setup, and it's evolved over time. And these are the 5 tasks, and I'll take you through them one by one. The first task is a transferring task. And what was different about this task as opposed to a lot of the other tasks that preceded this was that you had to use both hands in order to accomplish the task. Whether you're left-handed or right-handed, you have to pick up one of these pegs off a post with your left hand, transfer it in the air to your right hand, and then put it on the right-handed post. And after you've transferred all the posts from the left to the right, then you have to reverse this choreography. So the idea is that you have to be able very quickly and efficiently to be able to converge the tips of your instrument in 3-dimensional space. It's a very, very useful exercise, and in fact, the transfer of training from this very basic exercise to suturing is extraordinary, because you're not going to be able to tie a knot or to transfer a needle if you can't do this exercise. You can practice it, it costs nothing, there's no consumables, and you really can move your skill set forward, because you're going to get comfortable working in a monocular environment, you're going to get comfortable using both hands, and you're going to really know where you are precisely in 3-dimensional space. The next exercise is a cutting exercise. There's a template, a circle, and the idea is using your scissors, you provide traction with your non-dominant hand, and you cut out the circle, and any deviation from the line is an error and factors into your calculation of your score. This is an endo-loop exercise, so you have a hollow or a tubular structure. There's a black mark there. You have to secure that tubular structure just like it might be a cystic duct or appendix or blood vessels. And what you do is you take a pre-tied ligating loop, you place it at the line, and you secure it tightly to make sure that you've controlled that, then cut the endo loop. These are suturing tasks. The idea is it's a Penrose drain, pretty cheap. It's got a mark on either side. There's a slit in between. You have to put your suture through one mark, coming out the other mark, and then you have to tie a knot to approximate the slit. You have to avoid catching the back wall of this of the drain, and Because the Penrose drain is attached to the tubular structure in such a way that you can avulse it, it teaches you not to pull up too hard when you tie the stitch. It's actually very simplistic, but it really requires you to provide those skills that are necessary to tie properly, precisely, make sure your knot doesn't slip, that you're able to actually close the defect, etc. And you do it by both an instrument tie and an extracorporeal tie. So those are the 5 tasks. I will mention that over the next year or so, we're going to introduce 2 more tasks. One is a cannulation task that will mimic the cannulation of the cystic duct, and another one is a scope navigation task to teach people to use a 0 and 30-degree scope and target images accurately, so to really navigate around the abdomen, so to speak. And they will be add-ons to this box. So it just shows the versatility that's available. As I said earlier, the metrics reward efficiency and precision. They're objective, so they don't require any judgment on the part of the scorer, and that allows it to be reliable and to be used from site to site. We'll show evidence that the scores are reliable. That means that different examiners will provide the same score for any individual performance, and that if you're doing those skills on different days and you've kind of plateaued in terms of your skill level, you should be pretty consistent in terms of the score. And the test items all provide independent but complementary information to the total score. We're going to show that the scores are valid, and that is the scores that you get on this really reflect performance in the operating room. So again, let me just very quickly show you some of the data. Inter-rater reliability. So if you wanted to use this as a test for high stakes purposes, we want to show that the correlation between 2 individuals that are going to score you, or inter-rater reliability, would be greater than 0.8. And here you can see it's almost perfect inter-rater reliability, and that's a reflection of the objective scoring system. Test-retest reliability would be if you took the test twice without having a chance to practice a lot in between, your scores would be pretty similar to one another, and they are. And the internal consistency of each of the items reflecting the value or the total score is also very high. So we know that it's reliable. The face and content validity, we looked at an expert panel of the SAGES board. We asked them to look at the skills, identify those skills that they felt were fundamental to laparoscopic surgery, to tell us whether those skills were incorporated in the tasks, and identify any that might not be, and whether or not they felt the global rating, the scale that we used to measure, was a good measure of performance. And so they, as a group, identified that 14 skills that they felt were inherent to performing laparoscopy, that we had identified 11 of those in our tasks. And there were a couple that we didn't. One was camera navigation, one was cannulation, and they've both been incorporated. And the other one was use of electrocautery, and we felt that that would be better taught in a didactic rather than a hands-on way. So this is some of the scoring. We looked at 149 individuals varying in experience from a PGY1, a first-year resident, to a fifth-year resident. PGY6 reflect fellows. PGY7s actually are attending surgeons. And I want to call your attention to 2 things. One is that you see progressive improvement as people go through their training program. The other is that when people enter or first start doing laparoscopy, there's a lot of variability in their performance. By the time they get to be a chief resident, not only is their mean score better, but we've taken away the variability, and that's a sign of a good test. So we're happy with that. Each of the tasks shows an ability to discriminate between novices and experts quite effectively. You can see the 95% confidence intervals, which are these vertical bars, do not overlap one another. So it shows that it's really quite discriminatory. We then looked at 3 different gradations: junior, intermediate level trainees, and more experienced people. We looked at it through 5 countries, 215 candidates, and you still see this nice stepwise progression in performance in the manual skills component with no overlap whatsoever. So the test is really performing quite well. I will mention that there is a ceiling effect. The tasks are not enormously difficult, and that it doesn't take all that long before people actually can perform at a pretty high level. What we then looked at was how well did the FLS scores compare to our traditional way of evaluating technical performance in residence, where we have at the end of each rotation an evaluation of their clinical performance. And over the year in our institution, each resident is evaluated 13 times with 13 four-week periods. And we looked at dividing our residents into two groups based on their evaluations. And those that performed better in terms of their clinical evaluations were also the same people that performed better in this test. Not very specific to laparoscopy, but it was a way of trying to relate the real world to the simulated world. But in order to really do this well, we really wanted to develop a gold standard for the assessment of operative performance, laparoscopic surgery in the real world, in the operating room. And we wanted something that would be valid and would be the standard against which we would evaluate our curriculum. And Melina Vasilia, when she was doing her master's in education, developed this standard which we call GOALS, a Global Operative Assessment of Laparoscopic Skills. And it was validated looking at dissecting the gallbladder from the liver bed during a laparoscopic cholecystectomy, scored by two trained observers, by the attending and the resident doing a self-assessment. So there are 4 evaluations that were done for each performance. And we looked at 5 domains as listed here, each scored on a 5-point Likert scale with a maximum score of 25. And this is very rapidly what the score system looks like. So for instance, under depth perception, 1 would be constantly overshooting the target with wide swings, slow to correct. A 3 would be some overshooting or missing of target, but quick to correct. And number 5 would be accurately directs instruments in the correct plane directly to the target. So each of these would be scored by these 4 people from 1 to 5. We named it after our passion, which is hockey. We showed that there was good reliability, actually excellent reliability, no matter whether the trained observers were doing it or whether the attending was doing it, or even the resident self-evaluation. That each of these 5 scoring domains separated very well according to level of training, as did the total score. And that if we looked at each individual being evaluated both in the simulator and in the operating room within a couple of weeks of one another, you can see that we could identify that the expert people did better and that the correlation between performance in the operating room and performance in the lab was really quite excellent. So that we now had a way of showing that there was a link between what we're measuring in the simulator and what we're measuring in the operating room that correlated very well. And we could start to figure out what level of score in the simulator would predict the level of performance in the operating room that we wanted people to achieve, that of a senior resident, for instance. And we could come up with a passing score that would really reflect that value. And we were able to show that the FLS or Mistel score was an independent predictor of operative performance, independent of a level of training, et cetera. When we did the beta testing, as Lee said, we were able to demonstrate that very widely distributed this was feasible and exhibited construct validity and had the appropriate, not only psychometric properties as I outlined, but it was practical. It had the administrative properties that it could be used as a test. We've also been able to show that it had educational properties, the concept being that everyone goes through a learning curve. Rather than starting in the operating room over here by learning in the OR, if you practice in the lab, the idea is to get through this rapid phase of early learning and get closer to your plateau by the time you start operating on patients. This is a learning curve that we developed when we took a group of PGY3 residents, brought them to the lab every week for 6 weeks, and you could see their performance and their FLS score went up in a typical learning curve fashion. And then when we asked them to do a live animal suturing between the stomach and the jejunum, those people, whether they did intracorporeal or extracorporeal sutures that practiced, did substantially better than those that did not. It was evidence of transfer from the simulator box to a live animal environment. This is a randomized trial that we presented last year. Gideon Soroka, who was our fellow that time, showing that if you took a group of residents who were relatively naive, who performed poorly in the operating room, and you trained them to proficiency in the simulator lab, their performance not only in the simulator lab would be improved, but also their performance in the operating room would improve. And that was truly what our goal was, so that a group of people that did not practice regularly would not have passed FLS, whereas a group that practiced proficiency would have passed the FLS standard, and that the difference in performance in the trained group from where they started to where they turned out after an average of 6 hours of practice was the equivalent of a score of going from PGY1 to a PGY3. So the transfer of training was really quite impressive, and it's good evidence that practicing in this environment will improve your performance in the operating room. Finally, we had to come up with a way of cutting off or developing a passing score for this. We looked at a group of people who were non-competent of independently doing a lap chole and another group that did not, and we looked at their range of scores when they were tested in FLS. We constructed this curve, which is a receiver operating characteristics curve, and this allows us to identify a passing score that best distinguishes between these two groups by plotting sensitivity versus 1 minus specificity of the test, and we came up with a test that was able to do that very effectively. So to put this, to summarize all that, the manual skills component of FLS is inexpensive, portable, and practical, and it's a physical environment that we use to train people on the fundamental skills that form the foundation for performing laparoscopic surgery. We've shown that if you practice in this model, you're going to improve your skill not only in the model, but really in the operating room environment, that what we're measuring are not only reliable, but they're reflective of the performance characteristics that we value in the operating room. So to put it all together, I think we now have a curriculum that provides a uniform body of information that allows you to acquire the knowledge and skills required to do laparoscopic surgery. We have a way for testing for competency, and those people that pass will get a document, go back, that says that the successful candidate has demonstrated the knowledge and skills that are fundamental to the performance of laparoscopic surgery. It's not going to say that you can go out and safely do a lap chole, but it will provide that foundation for you. Thank you very much.